Good morning, everyone. My name is Iman Hakim, and I am the Dean of the Mel and Enid Zuckerman College of Public Health at the University of Arizona. I would like to welcome you all to this COVID-19 prevention seminar that is hosted by the College of Public Health and UA Global at the University of Arizona. As you know, we are all facing unprecedented challenges and uncertainties with COVID-19. And that's why we want to share not only with our local communities, but also with our global partner, the information and to exchange and discuss best practices. We are looking forward to partnership in research around joint research with our communities, global partners, not only to control and end this pandemic, but also to be prepared for future pandemics. I would like to thank all of the panel members that will participate today. And I will not take more time, but would like to introduce Dr. Casey Ernest, our Associate Professor of Epidemiology, who will lead and moderate this webinar. Thank you to all.
Thank you, Iman. Hi, everybody. My name is Casey Ernst, and I'm an Associate Professor at the University of Arizona College of Public Health. I'm an infectious disease epidemiologist. And it's my pleasure today to have this panel to discuss COVID-19. And we have some excellent panelists from the university who are going to provide some context and background initially, and then we'll move into an open Q&A session. And so we're going to have Dr. Kate Ellingson, Dr. Kelly Reynolds, and Dr. Kristen Pogreba-Brown. I would like them to introduce themselves so that you can at least see them on the screen. So Kate, would you like to start?
Sure. Hello, everybody. My name is Kate Ellingson, and I'm an assistant professor of epidemiology here at the College of Public Health, also an infectious disease epidemiologist by training, and I'm particularly interested in healthcare epidemiology.
Great, thank you. And next we're going to have Dr. Kelly Reynolds talk a little bit about infection control in the home and the workplace. Kelly, would you like to introduce yourself?
Yes, thanks, Casey. Hi, everyone. I'm Kelly Reynolds, and I'm Professor and Chair of the Community Environment and Policy Department at the College of Public Health, University of Arizona. My specialty is environmental microbiology, and I'll be talking about how we can control infection in indoor environments.
Great. And then we have Dr. Kristen Pogreba-Brown, and she's going to talk about how to engage the community and to work on more community level prevention. So Kristen, would you like to introduce yourself?
Hi, good morning, everyone. I'm also an assistant professor in epidemiology. I have a background in infectious disease epidemiology, and I actually teach outbreak investigations and run a student outbreak investigation course. So we've been relatively busy. So I'm going to talk about engaging between research and local health entities and other ways that we can engage both students and the community for this response.
And we're hoping that we will also be joined by Brandy Anderson, who is an infection preventionist and an affiliated faculty member with the college. She had some other work she needed to engage in, but we're hoping she can join us later. Brandy, are you by chance on the line and ready to introduce yourself? Or okay, I think she'll probably hop on in a little bit towards the Q&A session. So we're going to start with the—
To submit a question.
We're going to start with the presentation after I introduce you to where the Q&A poll is. So this is the slide that is going to give you information about where you can go to upload your questions for the Q&A session. And I'm just going to play this so you can get a little bit more information as to how to submit questions that we can have for discussion.
To submit a question for the panel, you can either open a web browser such as Chrome, Firefox, or Safari on your phone on the same device you're using to watch this webinar, or another device, and then type the bit.ly address you see below, bit.ly/COVID forum-QA. Or You can hold up your cell phone to the screen and use your camera or a scanning app to scan the QR code. You will see a pop-up and click the pop-up and it will take you directly to our Q&A poll. The Q&A poll will remain open throughout the event. Thank you so much for participating.
Great. So that should have given everybody the information and the time they needed to scan the code or go to the bit.ly address. And as you sort of have questions throughout either the presentations or just during the Q&A session, please do take advantage of that and type those questions into the response. And I will be monitoring those and bringing those to the panelists for further discussion. All right, so let's go ahead and start with Dr. Ellingson.
Hi, everybody. So I'm going to kick off this presentation with just a bit of an overview on the numbers that we are all looking at, poring over, trying to make sense of as this pandemic progresses. So we've all seen data from across the globe. Something that's different with this pandemic as opposed to pandemics that have occurred decades ago is that there's a rapid availability of this information. We've seen case and fatality data out of WHO, CDC, the European CDCs, national ministries of health, and here in the US, in state and county health departments are posting their case counts online. And this type of information availability allows us to rapidly visualize what's going on. And so what I wanted to do here is just take a few minutes to talk a little bit about the metrics that underlie those visualizations, and specifically confirmed cases, rate of case growth, and case fatality. And understanding the context of these numbers within sort of with the caveats that are associated with the locality in which those numbers are generated is really important, because we know we are not generating those numbers in the same fashion in different geographic locations. So what we would like to hear from you, our global partners, in the discussion session and in the panel is, how are you interpreting this data for action, and how are you using that local context and leveraging what you know locally to make sense of this information? So next slide, please. So this is one, I'm sure many people are following this Johns Hopkins global mapping site. So this is a website that's updated very regularly. As you can see, this was pulled from this morning. As you can see at the bottom, all of the sources from which they draw data. These data look very similar to other visualizations by ECDC and others. The Hopkins folks also look at a lot of sites in specific countries. So they go to China's Center for Disease Control and other specific resources as well, not just WHO. So you can see from this slide that it's been right. It's spreading across the globe. And in the next slide, just looking at the US, this is an example of a case visualization by counties. A lot of media outlets are posting data like this. This happens to be from New York Times, but this data is publicly available, and there's a link here where you could actually go and download that CSV data yourself. Next slide, please. So the visualizations that I just showed you showed confirmed cases, and I think it's important to discuss the sort of heterogeneity in COVID-19 testing, which has really generated really divergent numbers across the globe. And a lot of this is due to test kit availability and capacity. We know in the US, we've been slow to get up to speed with all of our test kit production and distribution. Different parts of the US, and we know different parts of the world, have different criteria for testing. Just weeks ago, the recommendation for testing was that a patient or an individual had traveled from a country where it was endemic. Now we are the epicenter of the outbreak. And there's also differences in test accuracy. And just to name a few of these, the current PCR test that is being used to confirm cases can sometimes generate false negatives. I've seen different sensitivity rates posted, but the one I keep seeing is about 70%. So that means there are some false negatives, some cases that aren't counted even though they're tested. Some people who are tested early on haven't generated a high enough viral load to test positive. Others may have mild symptoms, and so the virus isn't in a sufficient quantity in the nasal or throat swabs that are tested. Sometimes there can be errors in sample collection, handling and shipping, or technical issues with the test. So just something else to consider. We know in the US that case counts are an underestimate of the cases in the US, and cross-country comparisons are going to be affected by the timing of testing and also the aggressiveness. So we've seen in South Korea, for example, a really aggressive campaign, and they've been able to document many more cases. Next slide, please. So one of the things that we're looking at, you'll see a lot of graphs and discussion about exponential growth. And so this is sometimes a difficult communication point because we know that humans think in linear terms, even if what's happening in front of them doesn't match a linear pattern. And so this is called exponential growth bias. And it's actually been cited as one of the reasons why sometimes it's difficult to communicate to the public about the speed at which this pandemic is evolving. Next slide, please. So on the next slide, we'll actually see some of these exponential growth curves where you can see on the next slide, you'll see the case count, the rate of deaths sort of doubling very quickly. And so these, if you look at the world curve, this represents exponential growth. And you can see that different countries are at different places along this spectrum. When we're talking about deaths, so next slide, it's perfect segue. The case fatality rate is something that we talk about often. This is a very important metric, but it's important to note that it is not infection fatality, which is actually what we want to know. We want to know out of the people who are infected, how many died. But this is actually, we actually are only looking at the case fatality rate, which means out of the cases that we've confirmed, how many have died. Also, the case fatality rate is not the crude mortality rate, which is the rate of death in the populations. And so sometimes those get conflated, and it's important to think of those separately. Healthcare capacity also affects the case fatality rate. If our systems are overwhelmed and they can't care for cases, severe cases, people will die at a higher rate. And also population characteristics matter. So this is a table here from a recent JAMA article comparing case fatality in Italy on the left and China on the right. And you can see the differences in case fatality listed as 7.2% and 2.3%. And this is in part driven by the distribution of age in the population. We know in Italy, in this over 80 category in the purple box at the bottom, that there are a higher proportion of individuals who are over 90. So that's another issue, another characteristic that we need to keep in mind when we're looking at these rates. And next slide. So since case fatality is such an important metric, I just wanted to provide a few sort of take-home points. So the case infers confirmation by laboratory testing. So of course, there's going to be biases in this metric depending on testing capacity and testing patterns. Restrictive testing, so only testing the most severe cases, which is the situation we're in many places in the US today still, will inflate the case fatality rate because you have those more severe cases in your numerator. Aggressive testing, like we saw in South Korea, will sort of, display lower case fatality rates because there's more mildly and asymptomatic people in the denominator. When we're looking at case fatality in real time, we can often underestimate it because those who test positive today, might die in 2 to 8 weeks. And so that's also something we won't actually know those outcomes until we're a little bit further along in the outbreak. And finally, appropriate attribution of COVID-19 as a cause of death will also play into these case fatality rates. So attribution is complicated by comorbid conditions, by vital statistics and hospital documentation of deaths. And that's obviously determined by availability of testing too. If hospitals don't have sufficient testing capacities, then they won't be able to test people even posthumously. Next slide, please. So we're all looking at these data to try to figure out what's going to happen to us next. And so without getting into too much detail about these models, just wanted to put forth a couple of models that have been suggested for our state of Arizona. And the bottom line here is that these confirmed cases and case fatality rates are being used to sort of model these epidemic curves and what will happen if we flatten the curve. And so, depending on how we estimate those case data, we see pretty different estimates of what a surge is going to look like. So how many people will be hospitalized, et cetera. And so let's go to the next slide. And so what I wanted to talk about a little bit is how we're using this data here in Arizona. We're looking at all of our reported data, trying to make sense of it, trying to understand what the true rate of growth is in our state. So we are trying to factor in the fact that we were slow in adopting testing. We are also trying to understand and map out our demographic, medical, and social vulnerabilities as a state so that we can better predict where our severe cases and deaths may occur. And also we're trying to understand our healthcare capacity and geographic disparities in that capacity for space, bed, equipment like ventilators, healthcare workforce, and resources. And so we're going to move on to the next presentation now from Dr. Kelly Reynolds. But at the end of this one, in our discussions, we'd like to hear from our global community about how you're interpreting your local data, what kind of caveats you have in that interpretation, how you're using the numbers that you have for forecasting and planning. And also we'd like to understand sort of how you're communicating this data and what the public levels of understanding are. So with that, I will cede the floor to Dr. Reynolds, and thank you for your time.
Thanks, Kate. I just wanted to talk a little bit about infection control in different environments. We have the same general guidelines for hand hygiene and surface disinfection and some of these other topics listed here, but we know that there are scenario-specific implications, whether you're at work or at home or when the kids are back at school, and there are definitely culturally and regionally differences in behaviors and activities. So that's something that I'm hoping we can also talk about at the end of this presentation of what are some of the different interpretations of the guidelines and how are they being implemented in different environments. One example is that the healthcare environment is very well trained, the healthcare worker, on hand hygiene and hand washing and the frequency of that. But what does increased frequency of hand hygiene mean in a household environment? And the recommendation would be after coughing and sneezing, when you arrive at a destination or back at home, after using the bathroom, before eating. But what about after handling fomites or coming into contact with potentially contaminated surfaces like laundry or cell phones, computer keyboards, things like that, commonly touched surfaces. We also know that face contact can vary by different populations and behaviors as well. It varies by age, gender, and different activity levels. But in some of our studies, we found that the average amount of time that people touch their face, which could be the perfect transmission route for the COVID-19 infection, is almost 20 touches per hour. So looking at some of that quantitative data, we can estimate the probability of exposure and the probability of infection outcomes. And then use of disinfection, we know that there are different practices in the general population in particular in terms of what products they're using and the efficacy of those products, and if they're using the proper cleaning tools. If you're reusing rags, even if you're using the proper disinfection tools or products and using the proper contact time, an improper tool or a contaminated tool like a sponge or a rag could spread more contamination throughout the household. We know that there are recommendations if somebody is sick in the home for self-isolation, ideally if that person can stay in a room in a quarantine fashion and have their own bathroom facility, that's the ideal. But there are also recommendations that if there are shared spaces, that these spaces should be disinfected multiple times throughout the day. And then I know we've had some questions on our poll, and something that I already really wanted to talk about, and it's the face mask controversy. There's a lot of mixed information out there with the media and different experts and what they're recommending for use of face masks when people are in the general population and out in public. So that's something I think we can have a lively discussion on. And social distancing, there's a lot of misconceptions about social distancing, how far is far enough. Staying home doesn't mean staying indoors, but we're looking at some differences in interpretation of compliance with social distancing and different stringency levels across the globe that I'm hoping we can also talk about. Next slide, please. So I just want to do a quick overview about some of the characteristics of the virus that we consider in our risk assessment models, and that is how far they can spread. And so we've seen recommendations that a 6-foot distance is ideal for social distancing, but there are some studies coming out from different regions that the distance should potentially be up to 12 feet because of the potential spread for aerosols. We know that the survival of COVID-19 virus and also other coronaviruses in aerosols, they can survive for 3 hours and stay suspended in the air, and depending on the size of the particulate. So it could be anywhere from minutes to hours that these could stay suspended in the air. But we know that the large droplets do settle very quickly onto surfaces, and that is where the data is showing now for this specific strain of SARS-CoV-2 is surviving up to 72 hours on common surfaces like plastic, stainless steel, copper, and cardboard. But there have been studies with other strains of coronavirus that in feces, the virus can stay viable for up to 9 days. So we're looking at a lot of different data, a lot of different reports coming out with different scenarios. And the variability here could be due to differences in humidity or temperature and suspending media of the virus. Next slide, please. This is a general cycle of how pathogens overall can be transmitted throughout our indoor environments. And once a pathogen is suspended into the air and falls on surfaces, a lot of our commonly touched surfaces are what we're recommending people target. But we also know that uncommonly touched surfaces or low touch surfaces can be a part of this cycle of transmission, and so they shouldn't completely be neglected. But we need to really consider a variety of different routes of how we can become exposed and what different types of surfaces can become contaminated. And it's really an awareness of your behavior is really needed. So understanding what kind of activities you're involved in different environments, whether it be work or at home, and how you can really target those environments to reduce your exposure. Next slide, please. Some of the studies that we've conducted and other people around the world have conducted is using tracer studies. And in this particular study, it was a healthcare environment, and we planted a viral tracer, not infectious to humans, but a viral tracer that's very similar to common respiratory and enteric viruses on 2 surfaces in a skilled nursing facility. This was a 300-room, 300-bed facility with attached independent and assisted living quarters. And what we found is that from one wing of the skilled nursing facility where we put the virus on 2 surfaces, it spread throughout the entire facility and into the independent living quarters through cross-contamination and transfer, potentially from both the healthcare worker, but also patient mobility throughout the facility. And we found that 64% of the surfaces that we swabbed after only 4 hours tested positive for our tracer. So this is an example of how we can gather information for predictive models to look at exposure potentials and transmission potentials in different environments. Next slide, please. This is a similar study that we did in an office environment. And in this particular study, we implemented a very simple intervention, which was providing hand sanitizer, surface disinfectants, and tissues to the workers in the office building. This was a floor of an office building that had approximately 80 employees, most of them in independent cubicles, but there were common areas like a kitchen, a break room, shared bathrooms, and shared copy and office equipment. And we found that the same concept of putting, in this case, we put the tracer on a single employee's hands to mimic if one person came to work sick. And what we found that is within 4 hours, if you see the pre-intervention columns on the left slide, over 50% of the surfaces and 50% of the hands of the coworkers also tested positive for the virus. And that continued to increase slightly throughout the day. With our simple intervention, we found that we had a dramatic reduction in the risk, both the frequency of contamination on surfaces and hands, and that related to a reduction of about 80% in the risk of norovirus, influenza virus, rotavirus, and rhinovirus infection. So we're looking at these same types of models to predict through this type of data what a COVID-19 infection rate would look like and how we might reduce that infection. But from other viruses that are similar, we find that there's some dramatic reduction with very simple interventions. Next slide, please. Now, I just want to talk a little bit about how viruses spread in the home. We also did a household tracer study inoculating a single family member, an adult family member's hands. And after 4 hours, 100% of the family members also living in that household tested positive. So this really stresses the importance of isolation and quarantine within the household. The sizes of our families in this study range from 4 to 6 family members. But what's also interesting is that we swabbed hundreds of surfaces throughout the house and found that 98% of those surfaces tested positive. So really understanding that there's a need to be very diligent and routine in your frequency about decontamination of very commonly touched surfaces in the household. Next slide, please. So this is a summary of some of those studies that I just talked about, but also some other studies, in particular one that we did in a hotel where we planted the virus in a bathroom of a single hotel room and then followed the cleaning staff to subsequent rooms. And we found that our viral tracer spread to 4 additional rooms through that cleaning process. So this is where we really identified for this specific hotel that improper products were being used in that cleaning tools like mops and sponges and rags were spreading contamination from one site to another. And we found that through very simple interventions of providing effective products and disposable cleaning tools that we could reduce the spread of virus between the rooms by 87%. And you can see some of the other interventions we had, the different type of product and the health outcome that we predicted through some risk modeling. Next slide, please. So this is my final case study example of looking at exposure in first responders. We were called in to help the Tucson Fire Department because they had an outbreak of MRSA. They had 19 cases over a 3-year period, and 4 of these cases were very serious hospitalizations and also documented transmission to other family members. And when we swabbed pre-intervention, we found that almost 7% of the surfaces tested positive for MRSA. One of the things that we found in this particular study was that soft surfaces or upholstered furniture were highly implicated in the transmission of the bacteria. So we implemented a very simple intervention again in the station house with surface disinfection and hand hygiene using hand sanitizers, and we maintained 0 cases for the next 3 years and a very low rate of positives when we swab surfaces periodically over that time period. So we've just introduced a new infection control training for this population, the EMS population, and there's the YouTube link here that hopefully we can provide for all of you. In the last less than 2 weeks, we've had about 14,000 views, which I think speaks to the need for continuous training and reminders of some of these same guidelines that haven't necessarily changed, but we need to be more diligent about implementing them. Next slide, please. So some of the things that we've learned from our intervention studies is that hand sanitizers and surface disinfectants really do work, and they reduce pathogen load and exposure in indoor environments. Low touch surfaces and soft surfaces also play a role and should be targeted as well. The use of quantitative microbial risk assessment modeling is very helpful so that we can estimate the reduction of these infections and really show some evidence to the population or the general population that compliance with these recommendations can be very effective and that these simple infections are having a significant impact on risk. And I just put a link there to the list of EPA recommended products that are rated to be active against SARS-CoV-2. Okay, and the final slide, I won't spend much time on this at all so we can get to the next speaker, but there's a broader list at the WHO website of common myths and misinformation that's being spread in the general population, and something I think we can talk about what you're seeing in your countries in terms of recommendations and misunderstandings in the general population. These are just some that I pulled out that have been circulating. So thank you for your time, and I'll hand it over to the next speaker.
Well, good morning again, everyone. So I actually only have 1 slide. So, but mostly that's because a lot of the stuff that I'm going to talk about are things that we are just starting to work on. And so we're working on these community partnerships, and I really want to hear back from everybody there on what they're doing in their own community. So one of the things that we have started doing is working with the local health department in having students assist with case investigations and contact tracing. So one of the reasons that we were able to do this is because we already had kind of existing infrastructure in place. And so I think that this was, I worked in preparedness for a very long time, and I think we've definitely seen how having these relationships established in advance is great. And so I would say for those of you who are researchers on the call, reaching out to people you have existing relationships with, because a lot of health departments right now are really, they're very busy with all of the response efforts that they can do. And so one of the ways that we as a university have really to help is to say, you know, we're available and we can do this, and we're all in kind of response together. So the way that we have done this is something that's a little bit unique. And so we had an existing call center or surveillance lab that was already set up on campus, but it was a physical space. And so we had that we could have 4 students in there at one time, and they could go in and make calls, and we were doing routine surveillance with the health department. But when it became clear that we things that we have been doing that a very monumental effort on the IT side of things is we've now figured out to do a virtual call center. And so this has been something that we have worked with our IT staff to be able to have students virtually. They actually use Zoom.
Why you mute me?
They're having people do VPN in, so they're using the electronic system to be able to get so that we can access this type of kind of patient information. So those are the kinds of things that you as researchers and people who are actually working with the response, I would say to think about things out of the box, how you normally do your response, or how you normally do some of the things that you've been doing. Think about ways that you can do it in this new kind of environment, these new social distancing requirements, because we can still do a lot even if we can't do it in person. So that's one way that we've been doing it, is to be able to go virtually, to be able to work in this setting. And then the other things that we've also had students do is we've had them, initially our Poison Control Center was the kind of helpline across the state for people to call and ask questions. So I'm not sure if you guys are having additional kind of centers and other things, but having students be able to man those kinds of call centers has been great, because it allowed our providers to do what they really needed to be able to do, and then be able to go from there. So that's one thing. Sorry, I'm seeing that I'm having issues with my, okay, all right. So sorry, some people were saying they couldn't hear me, so I'm just gonna move in a little bit closer. And so engaging public health in ways that they can work in public health, which frees up other healthcare providers, is a way that we can have a good collaborations across the board for this. And then the last thing that we've done more locally is kind of just engage with health and the university as a whole to make sure that the messaging is clear and consistent. So we know that there's messaging coming all the way up from the federal level down to the state health departments, county health departments, and everything in between. And we really want to make sure that we have consistent messaging across those, so that there's less confusion for people. And that's one of the things that we've really made sure that we're looking at all those different messaging. And then as a College of Public Health, being a source of information that is consistent across that board. So that's one thing. And before I go back to Dr. Ernst, one of the things I guess I would like to look, or to kind of put out there, is we are also very interested. So there's a lot of acute questions, a lot of acute response, but the other thing that we are all very interested in is, what does this mean long term? Are there long-term health consequences? Are there what are we patient population long term? And for researchers, this is a really great opportunity to partner with people who are in the community to be able to answer these questions. And that can be everything from partnering with health departments to get an idea of the cases that are confirmed, as Dr. Ellingson pointed out. It could also be, we're very used to occupational exposures, thinking about healthcare providers as an occupation that's going to be highly exposed. But what about people who are cashiers and other things? And something we obviously are thinking about the questions about what is it like for them to be exposed to COVID-19, but now you have people that are using these, using cleaning products as they should more often, but how is that going to have impacts on longer term? So this situation has presented all of us an opportunity to come together and really answer longer term questions about the health of our communities, not just in this immediate time period, but also going forward. And so we, kind of challenge ourselves to think about that and think about people in our community that are going to be, that are put at most pressure in this situation, and how we can help by answering both the immediate questions and then also the long-term questions. So I'll turn it back over to Dr. Ernst.
Great. Thank you very much, Kristen and Kate and Kelly, for all of your excellent information. So I think what we need to do now is move on to our Q&A session.